I'm going to introduce our speaker tonight, and her name is Heather Coulter Jackson, and Heather is a registered dental hygienist and a sensory integration therapist. I'm going to be corrected on that, working in the fantastic special care centre in London, Ontario. And I've seen Heather speaking at the IADH recently on this topic we're talking about tonight, which is how to use sensory integration therapy for your patients with autism. And it was astounding. I just thought, this is someone who has it right. She just has it right. We need to let more people see this. We need to share this amongst dentists so that more dentists can do it right. So we are so lucky to have her all the way from London, Ontario, I think that's enough of an introduction, and I am going to pass it over to you now, Heather, if you'd like to turn on your video and your audio, and you can start sharing your screen. Hey, Heather.
Hey, how are you?
Yeah, I'm good.
Share my screen here. Hang on.
So Heather, tonight is going to be a bit interactive. It might be a little bit of chatting amongst ourselves. And is it okay? We do have the opportunity to bring other people online as well. So if there are people who do want to be a little talking head here, like above and below, come on, we can be the Brady Bunch together and we can come on. So don't be shy, guys. So Heather, I'm going to shut up and I'm going to let you do some chatting. But is it okay if I pick your brains as you go along?
Please do. I love questions from anybody. First of all, thanks, Kev, for having me. I really appreciate it. I think normally I do these from afar, and that just happens that I'm in Ireland at the same time with my adult son. We're going back to our heritage for his reading week. So anyways, I just want to give you a little bit of background on who I am. I've been a hygienist for over 30 years, and for 19 of those, I've been working in pediatric dentistry for Dr. Clive Friedman and Dr. Tim Michinari. So I've been very, very lucky that I have been able to do lots of extensive training in different things. So over the last 2 decades, we've traveled around the world learning all different kinds of modalities. We trained with Castilla Morales in Argentina. So what I've done is I've taken all of these bits and pieces from all of the things that we've learned, and we've put them together into a program to try to help kids to adapt to all different kinds of sensory issues. So the other thing we utilize is the training that the children get through the IBI, Intense Behavior Intervention, and ABA, which is right there, Applied Behavior Analysis. So the kids take that in Canada until they're about 7 years old. They go into a therapy program between 1 and 4 days a week. And those people set up different protocols to help them learn to tolerate care. So we amalgamate whatever they're currently doing into what we're doing in the office to try to make things a little bit more cohesive. These are just a bunch of different things. This girl has a guide dog, and obviously a lot of children with Down syndrome are dual diagnosis. So right off the bat, I'm going to show a video just so you can have an idea of what I do. It starts sideways, but it'll turn in just a second. This is a little girl named Cameron. I just want to let you know that all the parents have given consent to show the videos and the photos in this. So this is her second time doing the PGSI program with me. I'm going to show the video, and then we're going to kind of pick it apart and dissect it. If you have any questions, by all means, please jump in and ask them whenever you want to. So I'm going to go right ahead and play the video. It's about 4 minutes long.
Nice to see you again. Just want to put this beside you. Can we turn that off and give it to Mommy?
So one of the things I do here is we take away the cell phone.
Blue or purple? Blue. Do you want to open it, or do you want me to open it? Do you want to open it? Wow. Yeah, it's pretty cool. So what was the
just to see Dr. Nicholson.
Can you put your eyes down, honey, so it doesn't get... Hi, how are you today? My hair? Like this? Hi, how are you? Just like that. Listen to my counting, okay? 1, 2, 3, 4, 5.
What you can't see is that I'm putting pressure on her knees right now. Just can't see it in the video.
4, 5. Okay, sir. Thank you. 1, 2, 3, 4, 5. Good girl. Good job. 1, 2, 3, 4, 5. 1, 2, 3, 4, 5. And your shoulders. You ready? 1, 2, 3, 4, 5. And your ears. 1, 2, 3, 4. Hi, there you are. And again. 1, 2, 3, 5. Good job. Woo! Really? You're telling me about your day? So let's open your toothbrush. Can we open it up? See how much you get done. What do you think? You ready? That's a girl. My turn. Can I have a look? 1, 2, 3, 4, 5. And then you ready? 1, 2, 3, 4, 5. Thank you. Yes, is that right? Can you keep your hands down for me like this? We'll go back to your ears. Come here. Come here. Am I losing you? Am I losing you? 1, 2, 3, 4, 5. Thank you. Can you sit up for me, honey? Up again. Oh my goodness, I don't want you to fall. That's a girl. That's a girl. 1, 2, 3, 4, 5. 1, 2, 3, 4, 5. And your ears. 1, 2, 3, 4, 5. Thank you. 1, 2, 3, 4, 5. Yeah, those are my hands. You ready? Right. Okay. What do you think? You feel them? Here we go again. 1, 2, 3, 4, 5. Thank you. 1, 2, 3, 4, 5. Good work. 1, 2, 3, 4, 5. And here. 1, 2, 3, 4, 5. And then your ears again. 1, 2, 3, 4, 5. Do you remember my counter? Do you remember my counter? I have a counter for Mommy here too. Here's Mommy's counter. Mommy's is purple. Here you go. 1, 2, 3, 4, 5. See that, Mommy? 1, 2, 3, 4, 5. Hide yours. On your arm. 1, 2, 3, 4, 5. Thank you. And here. 1, 2, 3, 4, 5. And on your leg. 1, 2, 3, 4, 5. Thank you. And watch Mommy's. Look. Watch. 1, 2, 3, 4, 5. And your turn. 1, 2, just 2, 3, 4, 5. Thank you. And again. 1, 2, 3, 4, 5. Thank you. One more time. Thank you. Into your toe. Ready? 1, 2, 3, 4, 5. Good work. And you're on your head again. You ready? 1, 2, 3, 4, 5. Awesome. And your forehead. Here we go. Here we go. 1, 2, 3, 4, 5. Find your couch. Can you sit up? Watch Mommy. Watch Mommy, Robert. Watch. 1, 2, 3, 4, 5. And your turn. Here we go. Thank you. Oops. Oops. Here we go. 1. That was only 1. We're going to get to 5, and then we'll do your ears again, okay? Yeah. 1, 2, 3, 4, 5. Good job. And your ears. 1, 2, 3, 4, 5. And then your counter. Here we go. 1, 2, 3, 4, 5. Thank you. And your ears. 1, 2, 3, 4, 5. Good job.
All right. So,
Nice to see you again.
got to go to the next screen here. There we go. There we are. So what you can see in the video is everybody at my office must be really tired of listening to me sing and count to 5 for one thing. But essentially what we're doing is we're desensitizing her to each stage, and we're using her cues to tell us what we're doing. So I'm going to go back a little bit, and that just to start, I'm going to make an assumption that most people know a little bit about autism. I don't think I have to go through and explain autism spectrum disorders. It would just be a waste of our time. So I just put this in my PowerPoint for those who do have any questions or are not familiar with some of the different characteristics of it. This is our friend Matthew. Matthew's been coming to see us since he was very, very young. We treat him typically now. He lays on the bench. He watches a movie. He comes to see us every 3 months. The big problem we're having with Matthew is we have nowhere to transition him as an adult. There's just no other office that's doing this on adults. So anyways, this is just a generalized description of autism, but then it comes with all of these characteristics. And in my opinion, I've never met anyone who had all of them. Sometimes they have none of them. I've got 2 pages of these characteristics that they definitely classify with autism, but over the years we've kind of created a subjective list of characteristics, different things that are more associated with the dental office than they are to regular life. So this is what we have found in our practice. So I don't want to read my PowerPoint to you, but I am going to go through this one just because there's some important information in here. So Castillo Morales used deep joint pressure in his work to calm the body down. He used some vibration on the chest, pressure on the knees, the elbows, and the children that we were working on when we were in Argentina, a lot of them had physical disabilities as opposed to neurological disabilities. So I'm not sure how it came to be, but we decided that the children with autism and spectrum disorders really love deep pressure on their joints. And I'm not talking a little bit of pressure. We're talking about pretty major pressure on the joints, pushing on the elbows, pushing on the knees. And I usually start farthest away from the body if possible and then work my way up towards their ears, which they generally like a lot. So the next point is repetition. The tolerance level on kids when they know there's a start and an end, I could count to 5 100 times and they would be able to tolerate it. But if I counted to 100, they wouldn't see an end in sight. So part of it is the end. The singing works because some children, that if they don't recognize the numbers in the counting, they definitely recognize the notes in the counting. The other thing that we find with this portion of it is you can't fool them and drag the numbers out. You can't do a 1, 2. It all has to flow. It has to be the same. There has to be a sameness through the whole thing. Given choices. I think everybody likes to be given choices. One of the choices we don't give her is whether I'm going to brush or not. It's, do you want the blue brush or do you want the green brush? It's not, do you want me to brush, which opens up an invitation for her to say no, which we don't want. So the physical contact without permission is a really big one. I've seen a lot of people that work with individuals that are nonverbal make an assumption that it's okay for them to touch this person, particularly people with physical disabilities, but it happens with autism as well, where people come in and they just put their hands on the child without ever letting them know what they're doing or asking permission. So that's, I mean, obviously unacceptable for anybody, but particularly I find it useful with this as well. That goes right next to the next one, which is trust. They're trusting that when I get to 5, I'm going to stop. And if I break that trust even once, if I say I'm going to do this 2 more times and I do it 3 without letting them know, again, the trust is broken really quickly. The next one's kind of funny. I'm not sure why this is, but about 99% of the individuals on the spectrum like orange toothpaste. It's just that's completely subjective. And funny enough, she picked grape in this video. So. The sense when they are being liked or disliked. I've always had a feeling that children on the spectrum almost have extra senses than we do. I think they interact with their environment differently than we do. But they have an innate ability to sense with whether they're liked or disliked. And it's been a very rare occasion where I had a child that I couldn't make myself feel comfortable with. I do find, though, that if there's somebody else that comes in, if the parents are like that, the energy of all those people around them is definitely going to change the success or the lack of success for sure. Clear boundaries and timelines, we just talked about that one. That's the same thing with the counting and the singing. The music, a lot of times we start with the singing to 5. I'll ask eventually if they let me get to 10. Then sometimes if there's a song that they really love, I'll sing the whole song for them. So my office gets to listen to me sing all day. Aren't they lucky? Praise and rewards. And this can't be with judgment. A lot of the IBI and the ABA individuals train the kids, and they train them with rewards. And I've seen Smarties, I've seen Fruit Loops, chips, you name it, all kinds of things. And mine is not to judge that. If that is what gets the parents, gives them the ability to complete a difficult task, that wasn't up to us. So we have to try really hard not to judge in that. Kev, are there any questions? Yeah, you're muted.
Yeah, hey, how's it going? Yes, let me see if I can show my video as well. I can't. Okay, yes, there is some questions coming in, and we just had one. But before we go and answer that question, I have. Actually, let's go and answer that question. Let's go. Sorry, it's coming from Alison, and Alison is saying, "Can the method that you're describing, is it a gift, or is this something that can be taught?"
I think you have to choose the right person. It's a good question. I don't think everyone can do it, but I think a lot of people can use this method. I think you have to have the right temperament to do it, and you have to be able to read cues. And you know, I don't know if you noticed, but the little girl all of a sudden turns and she looks at me. And there has to be that connection between you and the child. I think it can be taught. I think it's something that many people can do. I think it's like anything, though. I don't think everyone can do everything. Does that make sense?
Yeah. So you're saying that it suits some people more than others, but it still can be taught?
I think that you have to want to do it. There has to be I think if somebody doesn't have the love of these children and the need to see them succeed, it's not going to be successful. And that goes with anything. You know, with any job that you're doing, I think there has to be some innate ability to interact with these children. That make more sense?
Yeah, I get that. So is this something that you naturally were drawn to then? Is this something that you feel is quite strong within you? If you don't mind me being personal.
It's actually developed over the years. I was terrified when I started. I'm not going to lie. I mean, the first day I went for a working interview, I had about 11 kids in wheelchairs and 5 kids with autism, and I was terrified. You have to do the background work, the legwork behind it. You have to be trained properly. And yeah, I guess I have been drawn to it. I've been working with individuals with special needs since I was a child.
And what is the training for this? I know you gave a list of techniques. Is there a training program in this method?
No, I'm currently, we've had a lot of people come into our office and we've trained them that way. There's a lovely dentist from Montreal that I'm sure you met, Chantel, when we were in the IADH. She has come and she spent a week with us, adopted this program, and I'm fairly certain she is using it on a regular basis in her clinic in Montreal. So there isn't currently a training for it, but I think it's something that if you understand the basics behind it, that you could almost self-train yourself in it. Okay. So that's interesting. Because I think really, in a way, it would be nice to have some type of, because I'm getting loads of comments here about training, and also nice to have some type of program for training us, I suppose. There's some more questions coming in, so I think we're going to take a few of these now as well at the moment. One is coming in saying, can this be used with adults, or is it just for children? Oh, no. It actually works really well as a transition. So I have another video of an older gentleman. You have to start when kids are young. The brain, by the time, I believe the age is around the age of 16, the Purkinjes in the brain stop developing in children with autism. Don't quote me on that, but that's the number I have stuck in my head. So age is a real factor here. We want to get these kids when they're young, but we need adult dentists and adult general practitioners trained in these methods so that we have somewhere to transition them from us. So what do I do with my Matthew? So Matthew comes in and I do this. Where am I supposed to send him? So yes, it works really well with adults, but it always works better when you start with children. The earlier, the better.
Okay. I think something that's I'm picking up when you're talking there about this is that like we're watching these videos now, okay, and we're asking, right, I know what people are thinking, like, do you need to be trained in this? They're kind of thinking, can I use this? Or am I unqualified to use this?
No, there's no qualification. The qualification you have is your training in dentistry or dental hygiene or whatever you're working in. If you're already working with persons with special needs, it's no different. It's not, I have been trained as a myofunctional, to perform orofacial myofunctional therapy as well, but that was way after I did this. We just this evolved. Okay.
So try it, copy it, try it. Yeah. Do you know, when I seen you in Dubai doing this lecture. No, I thought, I wish I could show this to as many dentists as possible so they would copy this. I mean, it's superb. I've seen so many dentists do this, and you do it fantastically well. So, like I said, I'm going to be very cringy in my. It's absolutely super. I think what you do is lovely. But I'm not going to interrupt anymore. There's loads of more questions coming in. We're going to hold off on that. I'm going to let you keep on talking. Okay, so I'll let you carry on there. So thanks very much. Keep on sending in the chat, guys. Send in the chat.
Okay, so the next portion of this is how do you implement it into your office? How do you figure it out? So we have some pretty extensive. They're not extensive. It's a 2-page questionnaire, but they're really designed to target the areas and the information we know. We need to know, of the 5 senses, which ones are they most intolerant of. Is it sight? Is it sound? Is it texture? Or is it a combination of light and sound? So we go through with the parents and we ask a lot of questions on how they handle things. A big way, or lost for my word here, an indication of how they're going to do in the dental offices is how they do for haircuts. If they do poorly for haircuts and for brushing at home, the chances are they're not going to be really over responsive to just normal, typical dental care, routine care. So those questions are all things we collect ahead of time. So we need to know if they had a negative experience. Experiential baggage is huge. So if I have a child that's coming in at 2 years old or 3 years old, they don't have a lot of experience in anything and they don't have a lot of memory. But if I have a child at 10 who's been through 7 different dentists, it's going to take me a heck of a lot longer to get them to a place of tolerance. And we have to avoid certain circumstances that bring up those negative memories of them from other situations, other experiences. So physical location is huge. So we try to see them in a really quiet environment. And the reason we do that is because a lot of kids that are on the spectrum have had a lot of physical testing done. We have a lot of dual diagnosis. This little girl, Down syndrome and autism, we have a lot of that. So some of them have had a lot of medical conditions, medical procedures, even psychiatric testing. So we try to pick an environment. And when Clive designed the office, he designed this great little, he didn't intend for it to be used for this, I don't think. But it's just, we call it our pre-sedation room, but it's a perfect environment because there's no stimulus, there's no, nothing to really distract them. But if the first time they came in, they want to be seen on the floor, in a beanbag, whatever, we see them wherever we can the first few times, and slowly we transition them. Obviously, the goal is to get them to tolerate dental care and a proper dental examination in chair if possible. So setting goals. This changes from appointment to appointment, and sometimes we go backwards a few steps. So sometimes we're brushing and we're scaling and everything's going along great, and then the patient moves and something hits and it bothers them, and now we're working backwards. We have to go back. So in that video of the little girl, you could see me kind of losing her, but then her positive reinforcement is the pressure on her ears and her forehead. So if I go back to that as a reward, that it works perfectly for her. I can get her back in. Using mom as a model is another one. So, but back to setting goals. Sometimes the goal has nothing to do with dentistry. Sometimes the goal is just to get the child to sit still for a few minutes. And the more experiential baggage the child comes in with, the longer it's going to take us to get to a place where we can do a proper exam. So on the day of the appointment, we also always check in to see what their current emotional state is. The 2 worst times of year for children in the dental office are the last 2 weeks of school and the first 2 weeks of school, because there's a lot of changes happening for them. And I find that those 2 weeks, we have a lot of emotional kids, a lot of behaviors those weeks because of the undecidedness of summer. They don't know what's going to happen. Then they don't know about school. So the learning method is whether they've done IDI, whether they've done ABA, whether they like mom to be modeled, those things. So this is all stuff we're getting ready, we're checking beforehand. We like to find out what the reinforcers are, because oftentimes the reinforcers, as I said, are food. But if we can switch those over to something like orofacial pressure or something like that. Exit strategy. With regards to that, we always like to end on a good note, on something positive. We don't like, I don't like the child to have a negative reaction, to have a trigger, and then I say, okay, I'm all done for today. Because if we're talking about a winning and losing situation, that means their behavior is winning over what I wanted to get done. So even if it's, I've been scaling along and doing well, and I have a trigger, we might go back to brushing. So we end on a positive brushing note, or we end on a pressure on their elbows note. So, these are just things you almost have to think out beforehand before you actually get going. So sensory overload is a big thing. Children on the spectrum tend to not do well in this environment. So this is not even a busy day for us. But to the child with autism, that baby's crying. My friend Jody is talking to the mom's asking questions, Clive's interjecting his piece, you've got the little girl spinning on the chair, you've got the dental assistant Natalie on the other one with another child turning the TV up, mom there asking questions. So there's sensory overload. So when we talk about the location and the timing, it's more about the first three, the sight, the sound, and the smell. The touch and the taste are things that we are going to work into as we go along. Are there any questions about this, Kev?
There's loads of questions, but you know what? Let's hold off back on. No, you're doing good. Carry on.
Okay. So what we do oftentimes is we bring the child in at a time in the clinic that is a little bit quieter. It's very difficult to do this. This is what our, this is what our day looks like. So the patients in blue are generally the patients that I see. So on this particular day, we've got FAS, ADHD, Leschnian, anxiety, autism. You can read them. So of all of those children that I'm seeing on that day, probably 90% of them I'm going to run some form of, whether it's counting, whether it's pressure, whether it's singing, something to help them to manage that. So having a common, quiet environment like our room is fantastic. But we also tend to run some quiet days, we call them, days where the doctors are away or they're not in the office, so that I can bring the children into the clinic and the clinic is completely empty. They can wander around, they can sit on the chair, go for a ride in the chair. Oftentimes they end up in that little room anyways because they really like it. And I'm talking about this little room, and this is this little quiet room. So you saw a little girl in this environment. She's sitting up. There are some books behind the door, but that's essentially all that's in there. Too much stimulation, I have found in my experience with children on the spectrum, gets them riled up. You can use it as a reward, but for me to have all kinds of things in there to distract them, that goes back to the senses again. So when you've got these children that I believe are interacting a little differently with their environment, and you add additional stimuli, it's just going to make them wound up. So when they come into this quiet room, generally speaking, if they have an iPad or they have a phone, I let them settle for a few minutes. I shut the door, leave them in there with mom. Then I come back in and they might say hello. When I come in to actually do any treatment or any of the therapy with them, I take their phone away and I just put it beside them and say, oh, yeah, we'll have that at the end. Very seldom do they balk at it once we get into the pressure on the arms and the whole way it goes. So this is, so again, implementing it. The two main triggers are, or the two main obstacles are money and age. So the question was about age. So this young girl has a service dog. Her name's Allison. She's been coming in since she was about 6 or 7. So her parents, and a guide dog is very, very expensive. So they have decided to invest the time and the money in this little girl. She comes in at the end of the day, always, sits on the bench. We're able to brush her teeth, clean her teeth, get a good comprehensive exam. We've never had to do any treatment on her. Her parents keep her teeth exceptionally clean. So that's the whole age. Money is a huge factor. So a lot, at least it is in Canada, a lot of dental insurance companies don't reimburse for stuff like this. So it's difficult to find a means of charging the patient. We've never really charged a ton for the program because we want to make sure that as many kids can enjoy it as possible. So now, Kev, you just popped back on. Does that mean you want to ask something?
Yeah, it's just adding in on there were some questions about money, which you've kind of answered. And I suppose something like, are parents happy to pay for this?
Generally speaking, we've had really good luck with parents. It's not luck. It's parents have been very motivated because they understand that doing dental treatment would mean a general anesthetic, which would mean hundreds and thousands of dollars if they can't manage the ongoing home care. So it starts out that we see them quite frequently as a desensitization, which kind of goes back to the Determine program or the 1,000 Learning program. That's something they both utilize. So in that, I might see them a month apart, 6 weeks apart, 4 or 5 times. But then as they become more comfortable, we lengthen those times out, eventually hoping to get them to a stage where they come in every 6 months. We see them and do it through that way.
So how many visits are you talking about when you sit down and say, okay, I'm going to put this patient through this intervention?
We do not know, because what you're getting something different every single time. Sometimes with children, we always say we're going to start with 2 or 3 visits and see how it goes and kind of go from there. I don't think there's anybody that I've had to see more than 4 or 5 times on that short time before we were stretching it out to 3 months.
Wow. Okay. I want you, you don't answer this, but what's your success rate?
Oh, I don't even know. I would say very high. There's very few children that don't relate to this method. There really isn't. No, it's not. I'm not doing the same thing. So I've shown you one video. There's a lot of other things that we do to help them comfortable. That same little girl that you saw earlier, the way I got her to learn how to keep the scaler in her mouth was to dip it in toothpaste, which seems ridiculous, but she loved the orange toothpaste. So I would put orange toothpaste on the scaler and then put it in her mouth, and that's how. It's not quite as cookie cutter as I'd like it to be because everyone's so different.
Okay. I'm going to let you keep on talking now, but just there's one question came up which is actually quite interesting there. What is the PGSI program? Could you describe it in 2 sentences? Patient guided. So I'm using the patient's cues, whether they be positive or negative, with regards to sensation, their sensory issues. So it's patient-guided sensory integration. We want to integrate what I do into their sensory triggers. That make sense? So this is a non-pharmacological behavior support intervention. Exactly. Where you do that. Right. Some of the kids we've been able to do some restorative work on. This is not eliminating the need for pharmacological interventions. I mean, some of these kids have had general anesthetics. Some of them have had heavy sedation. But the idea is we need to be able to do a comprehensive exam. We need to be able to clean their teeth. And we need to be able to have good home care. So this kind of, okay, I'm going to let you talk. Okay, thank you. Okay, so I'm going to show a couple of videos to talk about age and to talk about how this transitions. So you saw from the first video, the little girl was quite new to the procedure. You could see her kind of balking a little bit. This is Sage. Sage has been coming in since she was a tiny little thing. She does not have Down syndrome. She looks like she does, but she does not. I'm just going to play the video and then we can talk about it.
Awesome. I'll just get one of you to sit beside.
Okay.
Awesome. How are you? I'm going to put the phone down. I'm going to put the towel on. Awesome. Which color do you want, green or purple? You want toothpaste? Toothpaste? What kind of toothpaste do you want? Orange or grape? Grape. Grape? Awesome. Let's get our gloves on. Are we going to sing? Are we going to count? What are we going to count to? 5. Can you do it for me? Show me how we count.
We'll ignore what he has on his sweatshirt.
How are we going to do? Are you going to sing with me? Do we have toothpaste or no toothpaste? Toothpaste, thank you. You ready? Here we go. 1. That's a girl. 1, 2, 3, 4, 5. And stop. You gonna sing with me? Not today. 1, 2, 3, 4, 5. Should we count to 10?
Gummy, 5.
Just 5? Okay. 1, 2, 3, 4, 5. Thank you. And all the way back. Thank you. 1, 2, 3, 4, 5. Thank you. Good job. Good job. And again. 1, 2, 3, 4, 5. More toothpaste? Can you rest your head against the wall for me? All the way back? That's it, girl. Thank you. So we can do this side. 1, 2, 3, 4, 5. You got it? Awesome. Should we wipe it off?
All right, so what's interesting about this is that she started out as a typical PGSI with pressure and with the whole thing, and just slowly over time I've earned her trust, and Dr. Friedman has, so we are able to get the procedure done without going through the whole prelude. She now will go and sit on the bench. Part of the problem with her is that she is obese, and when she lays back on the bench, she feels very uncomfortable. And I don't know if you noticed from the video that they are quite flat. So she will now sit in the dental chair, and we clean her teeth, we scale them, we polish them, we do whatever we need to do. So that's the idea of starting any of these things earlier. But again, it comes back to we need general practitioners that are doing the same thing, because we have nowhere to send Sage. She isn't as old as she looks. She's actually only about 12 years old in this video. So let's go ahead here. This is another one. So he's very young. Would you prefer to watch the video for me to hear me talking right now, Kev?
I'm really liking having you talk over the video. I think it's lovely. We're kind of getting to pick your brains. I don't think we're missing too much of the detail while you're talking.
Were there any questions about that video or what we've talked to up to now?
Yeah, bundles and bundles and bundles of questions. There's stuff coming in about about your use of loops and torch, and how do your patients find that? It's
never been an issue. Not one time has anybody balked at my loops. It's just part of who I am. It's part of the whole process. I couldn't work without them. And Clive has always worn them. Timogen wears them. And the kids are just used to it. It's just part of coming to the dental office. So I've only had one instance where I was smacked in the face and it damaged my loop. But other than that, not a problem. You do notice I don't wear a mask though. And that I think might be too much.
Okay. And then there's another question that coming in about the use of this technique with kids who are non-verbal.
That first child was non-verbal. The little girl, Cameron, at the very beginning, the long video, she is non-verbal. This little fellow here is non-verbal. And Sage that you just saw, she would be considered to be essentially non-verbal. She will say a one word here and there, but there's no social interaction whatsoever. If you ask her a question, generally speaking, you might get like, when I said, do you want me to count to 10 or 5? And she says, no, she says 5 because she's used to 5, but essentially all of these kids are nonverbal.
Okay. And there's people asking, this technique that you're showing, at what points do you say this isn't working? So let's say you've done it once or twice, or how long do you go before you say, or indeed, how do you know when to say this isn't going?
It wouldn't necessarily be that I would stop and say it's not working. We need to change something. So I had a little boy one time in, and he was not reacting very well. And it was in the early days when I was just starting out, and I was fairly new to this, and the program hadn't really evolved. And I'm fortunate. I went to Clive and I said, I need your help. So this isn't working. I need your help. I don't know what to do with this particular child. And this is before we went to see Castillo Morales in Cordoba, Argentina. Clive came in and he put the little boy on his knee and wrapped his arms as tight as he could. He asked him first. He said, I'm going to give you a hug. And he put him on his knee and he held him super, super tight. totally unlike any of the things that we were currently doing. At the time, we were doing a lot more of the determined type programming, legs out straight, that kind of thing. So it's not really a failure. We learned what didn't work, and it's our job as clinicians to be like a detective and figure out what's going to work with that particular child. That answer the question?
Yeah. That answers the question. So when you're applying this, right, and you're there and you're doing the 1, 2, 3, 4, 5, are you thinking about what you're going to do next, or are you following the program? Are you like judging, oh, I'm going to shift it this way or that way, or does it just happen natural?
The whole idea of this is that it's patient guided. So I'm going to go on what they like. There are quite a few kids who don't like their head touched, or they don't like hands in their mouth. So you have to watch their cues, see their reaction, see how they're triggered. So for example, some kids get an examination without my fingers in their mouth. They have a toothbrush and a mirror. They don't want fingers in their mouth. So, and particularly with the gloves. So the whole idea of it being patient guided is that the patient is telling us what is working for them and what isn't. Now, having said that, I have a number of patients that I was treating very typically, going along, treating them the same way, and I realized that I wasn't pushing them enough. So I talked to the parents and said, listen, this is what I'd like to try. Are you okay with this? So we would, move them to the dental chair, move them to the bench to watch a movie, start to do something a little bit different. Sometimes it works, sometimes it doesn't, but they can always get better. Does that make sense?
Yeah, got that. Okay, no, sure. I'll let you talk.
Okay, so I'm going to play this video. This is his very first time coming in to see me. Sorry, I need a drink of water. He is the classic, those characteristics I read in the very beginning. He probably ticks as many boxes as any child I've ever seen, including the fact that he's come in spinning beads. They tend to some of the kids like those Mardi Gras beads, and they spin them. So I'll just play this video for you. It's a couple minutes long, I think.
I like to do, and then he'll throw them on the floor and pull them back.
You're now my dental chair.
And then he likes to twirl around his wrist.
It's just my hands. Have a look. Have a look at the glove.
So this is the whole connection piece here.
Isn't it? So listen to my counting. 1, 2, 3, 4, 5.
Again, it's pressure on his knees. And I'm pushing his wrist into his elbow, my hand behind.
Look, ready? 1, 2, 3, 4, 5.
So you can see he's warming to the idea a little bit here.
Oh, that's a big stretch. Oh, that's very nice. Oh, good. Okay, this one. Legs out straight, hands on your tummy, head is back, mouth is open. Listen to my counting.
So because it's his first visit, he needs to know what position we're expecting him to sit in.
1, 2, 3, 4, 5. 1, 2, 3, 4, 5. Thank you. I got your ears. Ready? 1, 2, 3, 4, 5. 1, 2, 3, 4, 5. Thank you. And then your forehead, you ready?
Now watch, all of a sudden he just connects in this one.
You want to spin your beads? Is that why you wanted to stand? You're going to spin them once for me? Hang them up. Spin them. Show me how it works.
He needs to do that too over space.
You're going to spin them on one side? Oh, that's a nice stretch. You're stretching today. Hey, can you sit back up next to Mount for me, please?
He's getting annoyed. That's why he's doing that.
Yeah. So, which color toothbrush are we going to pick today? Are we going to pick yellow or purple? You choose.
Okay.
Well, that's purple. You know what? You've done a really good job. Did you want a dinosaur?
So this is the reward that I've set up with Mom. Apparently he doesn't
Jack,
want
would
it.
you like a graceful or a giraffe? Have a look. Oh, yeah. Awesome. Let's open your purple toothbrush and see if it fits.
So again, I'm going to start far away from him. He's going to look at it first,
right.
but then I'll start at his extremities and work forward.
Stop. Thank you. My turn. Legs out straight, hands on your tummy, head is back, mouth is open. 1, 2, 3, 4,
Was a surprise that he just let us do this.
1, 2, 3, 4, 5. Stop.
That speaks to the fact that mom brushes his teeth at home.
4, 5. Good job. 2 more times on the top. 1, 2, 3, 4, 5. Thanks. 1 more time on the top. 1, 2, 3, 4, 5. Stop. Good job. Low five, high five. Awesome. Let's take a break, okay? Awesome.
All right. So I think I mentioned that we would like to end on a high note. We want to make sure that, oops, I did something to the computer. We want to end on a high note. We want to make sure that he's happy when he's leaving. I don't want him, again, to have some trigger and have him leave. So basic steps with the program are to gather, we talked about gathering the information at the beginning, setting up the environment that be the least stimulating, introducing him to the environment, him or her, in a non-threatening way. So having them walk around the clinic, having him read a book in the room, whatever we need to do. Setting up the boundaries is the counting, the singing, the legs out straight, all of the different aspects of what our expectations are. The pressure we've talked about, and the whole goal here is to work towards an intraoral examination. We want to get a good exam for these children. These are just some of my own general tips, giving choices. I use a parent as a model often, which I have some instruments for them. I have instruments for their child. I'll have 2 toothbrushes sometimes. I'll touch mom and then touch the child. We try to use a lot of praise in our voice as well. I mean, you can say, good job, or you can say, wow, great job. And they seem to really respond well to the positive reinforcement, depending on what they currently are doing at home for that as well. But we want to praise the small successes so that they grow into big ones. So as I said, leaving on a positive note. Then what we do is we try to make sure that the parent is doing the same thing at home as we're doing there, that they're not cheating the counting to 5, that they're using, if they want to sing, they can sing. If they don't want to, they don't. But oftentimes after the first visit, if a parent puts the work in at home and they're working with that child, when they come back is really evident. So you can see that Sage came in and she's sitting with her mouth open. This little boy's mom obviously brushes his teeth because as soon as he saw the toothbrush, he put it right into his mouth. So, and again, I talked a little bit already about giving a little push sometimes. So the goal of this is to have children. So I'm going to go back to Cameron because this is, so we're talking a few months. So the original video was last summer, and she happened to be in last week, and so I took this. So that's Timogen Airy for people who don't know that. I'm just going to play it. It's only about 7 seconds long. So he's using a mouth mirror.
4 and 5. That's great.
Setting up the same system, and she's tolerating a good dental exam.
4, 5.
So part of the question we had in the past is it just because it's with me? Am I the safety? But if we set up the safety in the office, in that environment, it doesn't matter who does the counting, who does the singing. If they know they're safe in that environment, they respond like this. This is another fellow here. I've been seeing him for quite a few years. I showed some video of him in the last presentation I did as well from his first visit. So this is... He's laying on the bench. He's watching the movie. Dr. Ari has his loops on, and he's tolerating a proper examination. So that's kind of the end of my program, and I thought if anybody wants to ask some questions. You're still muted right now, Kev.
Yeah. Had the legs up there. Heather, yeah, lots of very interesting stuff coming in. The question that's come up a few times is, can you do this for kids who don't have autism, who are just anxious?
We use the counting and the singing on children of varying degrees of special needs. So you have a child who comes in, or even an adult who's very, very anxious. If you set up those clear boundaries of counting, you don't even have to, you can say, listen, I'm going to count to 3 and I'm going to stop. If they know there's an end to it. So Down syndrome, it works really well in children with Down syndrome, even if they're not dual diagnosis. Any of the kids on that list, that list of all of the schedule that day. So you saw that, and even just plain anxiety. Okay, one more right here. So all of those different syndromes we use this for. The other one it works, the only thing that it probably doesn't work as well on is ODD, oppositional defiance disorder, but that's a very difficult one anyway, because they're not doing what you want them to do.
Yeah. Okay, I'm getting another question in then as well about the 1 to 5 and the parents at home. Are you getting the parents to copy that 1 to 5 technique exactly at home, or can you tell us a bit more about that?
I get them to do exactly what I do at home.
Okay.
So not that they don't do the oral pressure and the pressure on the joints, but when they brush, I ask them if they don't mind singing. They sing it, and the kids come back in and they know the song. They're singing it back to me. So yes, I set it up exactly like that at home. But we explain to the parents that obviously they need to be in there and getting the teeth cleaned. So even if they could if the time is very short, I would rather see them brush the top teeth in the morning really well and the bottom ones at night really well than do half of them half cocked. You know what I'm saying?
Yeah. I want to come back to the counting again, because there was other comments on that there. And one person was saying, the counting, is this just a primer, or do you do this for every procedure all the time?
Well, eventually, once they become accustomed to what I'm doing, so it's a desensitizing program. So with Sage, now when she's in, we don't count, like Dr. Ari is counting for Cameron in this picture, but we're not counting for Tyler anymore. The only time we would count for him is if we're doing something new. So he knows how to, and sometimes if they're having an off day, we will go back to the counting. But generally speaking, it's used as a desensitization tool.
Okay. I'm going to go on to a few questions coming in now about the pressure that you're using and a few aspects of that there.
Mm-hmm.
First one, I suppose, is do you tell the parents about the pressure and the touch, and how do they respond to that?
They know before they even come in for their visit. We have an excellent treatment coordinator at our office. So she goes through, Maureen Privet's her name, she goes through the whole program with them at their consultation appointment. They know exactly what they're getting into.
Okay. And then when they see it actually happening, how are they when they see it actually happening?
They want to do whatever they can for that child to learn to tolerate care, is what it comes down to.
Mm-hmm.
The other thing I didn't mention that I want to interject here is that you'll notice that the parents are all silent observers. That's kind of a typical thing we do in the practice, is that you can't have two people nattering at the child. And as the child gets louder, I tend to get quieter, and my voice gets quieter and quieter, so they have to really listen to hear it. And I find that can settle them down as well.
Okay. Ben, coming back to the pressure, the amount of pressure that you put on, how do you know if it's right or wrong?
By looking at the patient's face. So you're looking at them and I mean, you're not going to hurt this child, and you're putting the pressure that you would put on if you were to drop an orange and pick it up. And you're picking it up off the ground, you have to put some pressure on it to lift it up off the ground. That's the type of pressure you're starting with. But some kids will take your hands when I've got them on their head, and they will push their hands on my hands, which means push harder.
Okay. I'm going to move on from the pressure, and I'm going to ask you about your song, and tell us about how you use the song, or what are the core elements. So what I'm thinking about for the people who are watching this now, give them some advice about how they might use this song on Monday.
What's kind of interesting about the song is that it kind of just evolved. So we were doing the counting and letting go, and and it was annoying me. And so now the singing probably annoys everybody in the office too. So I started kind of doing the singing, and it started working. So then we had Martine Hannekin from France down, and she was using a lot of music therapy on our children with Down syndrome. We had some that were really difficult to manage. So it's kind of morphed from that. There are a number of children that come in that I just sing songs. My grandfather taught us some ridiculous songs from the 30s and 40s, and unfortunately they're all stuck in my head. So
I'm going to switch again just while we have you to pick your brains. The way in which you're asking questions to prepare, do you have a set list of questions that maybe you could share to these people?
I don't have it with me, but I'd be more than happy to get it to you, and you can upload it onto your website.
Yeah, that would be awesome. I think it'd be good for, I think as we come to the end of this webinar, I'm thinking about the 115 people who are still on, and I'm thinking like what I'd be going through my head if I was one of them was, how can I make this happen tomorrow? How can I make this something that I do? So is there anything any hints or advice you can give to people watching about how they might integrate this into their practice tomorrow?
I think that you need to, if you're already seeing adults or children with autism spectrum disorders, you already have a knowledge base. So implementing something like this is fairly easy. You just kind of have to have some confidence in it and start slow and start with one aspect to begin with. Start with the counting and see how that works. And then, add the pressure in as time goes on and see if those are things that your patients are responding to. Again, it comes back to the patient-guided piece of it.
Mm-hmm. Yeah, I like that. So go for it. Try it.
Go for it. I say go for it. Yeah.
I'm getting some more stuff about the beds. The main dentists have spotted that you're actually using non-mobile beds rather than dental chairs. Is that something that you guys have done on purpose?
Do you know what? That's Clive's thing. So I don't know where he got the idea from, but the office is extremely well thought out. So that bench looks remarkably like an ironing board, really. And he has the TV set at such an angle above it that the children raise their head to see the television. The other reason that he chose these is because a lot of anxiety in dentistry, particularly in children, is the moving chair. They don't mind it going up and down, but they don't like it going back. They have this, this fear of that. Children with Down syndrome in particular that have some issues with their head and neck really don't like to be moved back, but they'll lay down on the bench.
Okay. Do you want to shout out your website so as that people can find some of these resources?
Well, our office website is Pediatric Oral Health and Dentistry, and it's out of London, Ontario. We call it POHD. And I'd be more than happy to talk to Dr. Ari and Dr. Friedman about giving you a link that you can even link into some of the stuff on our website.
Yeah. There we are. Alison is after sharing that there on the chat, so that's fantastic. Much better. It doesn't exactly roll off the tongue. The pediatric dentistry and we're getting loads of feedback here from people saying that they're greatly inspired and they're getting lots of ideas for what to do in their surgeries with their patients.
I'd be more than happy to help anybody, and if they have any questions afterwards, you're more than welcome to email me. I'll give my information to Kev, and if there's any questions or any additional information that people are requiring.
Yeah, that's super. Well, look, I'm gonna wrap this up because we've come to the end of the webinar, and then there's usually a few hang-arounders like me chatting for a little bit afterwards. But first of all, wow, you nailed it. This is exactly what I was hoping that you'd do. I knew you'd do it. You come on and you masterclass. I'm really just showing off. I think I'm really just showing off that the stuff that you're doing is just super. This is what I want my students to be doing when they qualify. This is where we should be going. It's absolutely lovely to see you do it. There's moments in those videos, and I'm sure people watching will agree, where you're just kind of going, "Oh, that's lovely." That's like,
it's hard to watch the videos from my perspective